Joanna, this is Ajay. I just wanted to say hi. I don't know anything about what you're going to do, and I'm going to hand it over to Sushil and Samir, but I was just super proud that you're transmitting, and I just wanted to say hello. So, can you hear us? I don't know if you can hear us.
Yes, we can hear you.
Okay, great. So Joanna Wykrzykowska, she's basically presenting a great case here, and I'm going to hand it over to Sushil and Samir and the others, but I just wanted to say hi, and we're super psyched. Thanks so much for transmitting.
Great, thank you, Ajay.
Ajay hijacked the mic to say hi, so we're going to now start with the session. Samir Kapadia and Pradeep Yadav are going to over to them, but welcome.
Thank you. Live case, we have a large audience here, and everybody is waiting to see that how you are going to present your case, and maybe you can introduce your team. Dr. Pradeep Yadav is my colleague here, and Samir and Joanna, thanks for doing this for us.
Nice to meet you, everybody. Welcome to UMCG in Groningen in the Netherlands. So let me start by introducing indeed my team. I'm Joanna Wykrzykowska. This is my colleague, Dr. van der Heuvel. There we have the anesthesiology team, Wim and Yolanda. And next to me is Maria, one of our nurses, Salma, who masterfully prepared the valve, Kelly, Hannah, Kees is our PhD student, and we have also Franz, our physician assistant, and we have also Mr. Pillai from Merrill Life who joined us today. So why don't we, without further ado, present the patient case, and Kees will do that. So please let's go to the slides.
Yes, thank you, Joanna. Today's patient is a woman of 88 years old. She has a BMI of 24.5 kilograms per meter 2. Her medical history includes hypertension, and she has some severe aortic stenosis since 2023. During workup to the aortic stenosis severity, she was diagnosed with hyperthyroidism, which is now good under control. Her other surgical history includes total hip prosthesis on both sides. And since 2024 April, she has some exertional dyspnea with NIA class 2. Since then, she had a decline in her left ventricular ejection fraction. Therefore, we started with furosemide, and therefore she is now with us today. Her Euroscore was 2.1, mainly because of the NT-proBNP of 3,000. The other lab values showed no abnormalities. When we go to the EKG, we can see that she has a known left bundle branch block. On the echocardiogram, we see that she has some mildly reduced ejection fraction of 44%. And when we go to the aortic valve measurements, we see that she has a Vmax of 4 meters per second, a max peak gradient of 78, which brings us to a mean gradient of 45 millimeter mercury. Their AVA is 0.71. Her coronary angiogram shows us that there was no significant lesions on all territories. And when we go to the axis, we can see that on the right side there is some mild or some moderate tortuosity. So we go to the left femoral, and you can see that there is some mild calcifications through the tract, and that the median or the minimal left femoral diameter is 9.7 millimeters. When we go to the annulus, we can see that she has a perimeter-derived diameter of 24.5. The area is 469 millimeters squared and a perimeter of 77 millimeter. And there are some calcifications mostly seen in the non-coronary cusp. When we go to the sinus of Valsalva, we can see that all the dimensions are a bit small, below 30, especially on the right side. So self-expandable valve is not suitable today. When we go to the height of the coronaries, we can see that the right side has a height of 18 millimeters and the left side is 12.5. So back to Joanna.
Thank you, Kees. So in conclusion, we have a lady with normal flow and high gradient aortic stenosis, so a classical aortic stenosis with a little bit reduced ejection fraction of 44. We are going to choose here a transfemoral approach because her vessels are so beautiful. Based on the dimensions, we will close with MANTA, and as bailout we'll use a 12 millimeter stent if needed, covered stent, because we mentioned the sinuses of Valsalva are less than 30 millimeters, so it's below the IFU for Evolute or for Accurate, and so the natural choice here is actually MyVal, balloon expandable valve from Merrill Life. We'll oversize it about 5 to 10% given mild to moderate calcifications, and so we chose 26 millimeter MyVal with minus 1 cc of contrast. Next. So what is MyVal? I don't know how familiar you are with the technology, perhaps even more than we are, because this is a technology from India. Balloon expandable valve with large, nice coniholm cells up top, a fluffy skirt that actually ensures that there's very little PVL. The leaflets are impregnated also with anti-cal for durability. It has CE marks since 2019, and of course some of you perhaps have seen presentation of the results of the landmark trial, which shows in non-inferiority of this valve against Evolute and Edwards in landmark trial at EuroPCR, and also the publication in the Lancet. And of course around the world there have been a lot of implantations of this valve with good results. Next. So I think these are some nice features of this technology. You have multiple bend markers on the valve which ensure good positioning and placement, and usually we sort of set the positioning with the second dense marker to make sure that we are 20 to 30% on the ventricular side and 70% to 80% on the aortic side. Next. So you can see this here. Next one. Next one. And of course, the other very nice feature of this is you do not have to load the valve in the patient. The valve is actually crimped on the balloon, and Selma has already done it for us here behind me. So we can basically, we're ready to go. Next one. And it goes all the valve sizes, beginning with 21.5 up to 32 for the large people in the northern part of the Netherlands. We can all go through 14 French Python sheath. Of course, for the larger sizes, we have to dilate the sheath with 18 French dilator. Next one. So this is the table that we usually use to decide the clep size and how much we're going to oversize. So as you can see, perimeter-derived diameter of 24.7 and mild to moderate calcification. So we'll oversize about a little bit more than 5%. And this is the sizing table with all the sizes, and then also plus, min, so many cc's of contrast in the balloon. And you can see that we come out at a 26 millimeter device. And I think the other good features, as we also saw in the presentation of landmark trial, is that although this is a balloon expandable device, we can achieve very good effective orifice area, comparable to self-expanding Evolute effects. Now, so without further ado, that was the theory. Let's show the practice. We've already obtained access on the right side for catheter guidance and on the left side for the valve placement. So we're going to go ahead and actually cross the valve. So we use Amplat's left catheter, diagnostic 1.
Joanna, this is Pradeep. Joanna, thank you for presenting this outstanding case. Just we don't have experience with MyValve in the United States, so a question for you on sizing and how much oversizing do you need MyValve? Is it same as the other balloon expandable Sapien? And your thoughts on 24.5 versus 26 in this case, considering that
Yeah.
non-coronary leaflet is very extensively calcified?
Yeah, no, so this is a good point. I mean, I think you have a lot more choices here with sizing, and you can more accurately fine-tune it. I mean, I think if you looked at the area, then you would probably size it with, for instance, Sapien for 26, right? But it would be a little bit oversized as well. And yeah, here you have a little bit of room to play with it. I think systematically you also end up upsizing a little bit because you size on the perimeter derived diameter. So when you do that, obviously you force sort of ellipsoid into a circle and you end up with a little bit higher surface area. So Ad is trying to cross the valve. As you can see, we use Terumo wire straight to do this.
Script gave me 2 minutes to do this.
Yeah, so he's mentioning that he was supposed to get it done in 2 minutes, but I guess the anatomy, although it's not extremely calcified, it is quite fibrotic and quite severe. Yeah, that's it. He almost pulled it back. So we are across the valve. We have a little bit of extras. We are going to, of course, we know what the diagnosis is, otherwise we wouldn't be here, but we will also show you the gradient. So our tracing is a little bit dampened. Anesthesia is showing us blood pressure in the arterial system of 120, and then in the ventricle we have about 160. So we definitely have a large gradient. So now we'll use a safari wire.
So just a question, Pradeep, since we don't have the my valve in this anatomy, which valve would you use, a self-expanding valve, or in which kind?
Yes,
We
that's
have
why
two
I
of
was
them.
asking that, the question of sizing, because it is on the lower end of 26 Sapien 469.
Yeah.
So self-expanding would not be unreasonable.
Yeah.
So Pradeep,
Yeah, so
we
it
have
is,
this quarter
it's not
sizes
quite
in
the
my valve.
smallest
That
annuli
gives us
like in the SMART
a
trial,
in
because she
borderline lesions,
obviously has an area of
analysis where we
460,
take 21.5
but it is
or 24.5.
still a small
And
lady.
suppose we have an intermediate kind of analysis and we don't
And I
want a very
think for
otherwise
evolute we would
classically
have
if you have a
used
small annulus, then
29
you would always
millimeter
prefer
evolute
a
probably.
supraannular
for-
valve, self-expanding. But if there's a gray zone where you can have intermediate size annulus, you can opt for this, and especially if it is not a very
And
heavily
for
calcified
Edwards it would be
anatomy.
at 26 Edwards.
So our signal's a little bit, oh, now
So
it's
with
better
the
again. Can you hear us
wire
okay,
in the
Joanna?
ventricle, we are putting in the Python sheath now. We're going to tell this lady that there comes a point in this procedure that it might be a little bit uncomfortable.
Gevoelens zijn nu in de linkerlies. Er komt een dikke katheter.
Joanna, can you hear us?
Yeah, I can hear you now very softly, but yes.
Okay, I think we had lost you for a little bit. Just okay. Are you going to pre-dilate? You said with the what balloon?
No, we are not going to pre-dilate
Oh,
because
no.
usually what I do is if this valve is extremely calcified, and or if the size is 27.5 or above, so 29 plus, then we tend to pre-dilate. But it's a balloon expandable device of 26 millimeters, so we don't need to pre-dilate the valve itself. What we will do is we will make sure that the sheath is pre-dilated with an 18 French dilator.
Does the dilator go all the way out of the sheath, or does it stay in the sheath?
It goes all the way out so that it's completely split. And then we don't have much resistance when we actually introduce the valve. So we've checked the ACT. We have an ACT of 300. So we're good to go. Any other questions, guys, before we introduce the valve?
you pacing on the wire, or do you have a separate pacer?
Yeah, we're going to pace on the wire. Most of the time when we use the Safari, which sits nicely within the wall and makes a good contact, we don't get any extras and we feel comfortable pacing on the wire. So we're going to, with the valve in and the wire isolated.
No embolic protection, right?
So this is the valve. If you can maybe focus now a little bit on our hands. Yeah, okay. You can see here the handle as well, which allows us for torquing up top to go around the arch and flexing the mechanism. See, this is the valve coming through. So he's nicely crimped, sits between the stoppers. Shall I flex him there a little bit? I'm going to flex a little bit. Okay, well, the wire is going in a little bit far. Okay, can you, pacemaker? Yeah, can you test the pacemaker? Okay. So we're still above the valve level. Okay, perfect. We're going to cross the valve. Yeah, a little bit push on the wire. I think I'll take out the flex now. And we're going to check the position with our angio. Yeah, it's not unreasonable, I think. We are precisely, the level of the annulus is precisely at the second bend, I think. So I would be comfortable placing it like this. Okay, why don't we then start pacing? 120, 80, yeah? The pressure is, okay. One more time, check the position. Okay, and I'm going to start. Okay, yeah. Stop pacing. Okay, fantastic.
What is your goal for implant depth in general? Is it like, you know, there's
There's
always a lot of different camps. I know, Samir, you're always a 0 person. I try to be 2, other people are like 4. Joanna, do you have a specific depth that you're aiming for with these implants? Or is it based on the top
so
and the coronary?
20% under on the ventricular side. I mean, I think we're maybe a little bit deeper here. What we will do is we will actually remove the pigtail with the J-wire, and then we'll take a picture so you can assess in 3-cusp view the height of the valve and also if there's any PVL. So that actually we're keeping the system for now in, because if we say that we had a lot of PVL here, which I don't expect with this valve, we can always go back with the balloon, add 1 cc of contrast and actually do the post-dilation with this balloon.
And this was a nominal volume used for the first deployment?
-1.
Kan iemand de metrateur aansluiten? Even ontkoppelen en aansluiten. Ja.
And the depth may look a little worse than what actually it is because its parallax is still there. So it may be.
Yeah, there's a little bit of parallax. We'll try to get it parallel for you.
Thank you.
Ja, koppel maar.
Yeah, see now it's nicely aligned, I think. So we just changed the position to a bit more LAO look. This is precisely what we usually see with this device. With a lot of other devices, you need to wait 5 minutes for the skirt to warm up to have 0 PVL, but this is nothing, right? This is no PVL.
No, very nice.
So I think, yeah. So Ad is taking out the device already.
So one question is that when the sinuses are so effaced, Do
Yeah.
you use anticoagulation for 30 days or 90 days or something like that in these patients?
No, not routinely. This patient will get just aspirin. So, of course, what you're probably alluding to, okay, is there more risk of halt by this patient? I mean, I don't think that we have evidence yet to say that we're going to anticoagulate with rivaroxaban, NOAC, or for 1 month or two.
No evidence,
But I
but
would
we
be-
do use no evidence, but we do use anticoagulation in a effaced sinus, or where you're not confident of the circularity of the valve for heavy calcium, and the bleeding risk has to be low. Then we'll use it for 3
Yeah.
months.
Okay. It's
often you use
I mean,
it,
I think
Sushil?
that's an active area of research. We have just finished here in the Netherlands a trial that talks about what do you do about anticoagulation peri-procedurally. Should you continue it or stop it? What are the disadvantages? So I believe that will be presented at one of the European congresses sometime soon. And of course, it's a sort of active area of research. I think there's also an Atlantis trial from Württemberg, which will also address the issue of HALT and do you need to put patients with evidence of subclinical HALT on CT on anticoagulation.
Do you usually check the hemodynamics of the left ventricle, or because
Yeah, so sometimes we do. We do it mostly for self-expanding valves to make sure that we didn't miss under expansion in one of the areas. But I mean, I'm fairly confident here with this balloon expandable device that it's perfect. It doesn't leak. It's well expanded. We showed you in a couple of views as well that it's well expanded. So we usually don't check the gradient again. And I think post-procedure gradient says a little bit less about the function. We'll do an echo later today or tomorrow morning before the lady goes home.
an echocardiogram not at the time of the procedure, or usually only if there is hypotension or something?
Yeah, only for emergency issues do we do an echo here, but most of the time we do an echo simply tomorrow morning before she goes home and then 30 days later. So what we're going to do is we're going to reverse heparin with protamine, and we'll start to close the left side with the Manta device. The blood pressure is a little bit on a higher side, 177 by the anesthesiology. So hopefully the protamine will reduce it, and maybe we'll give a little bit of medication to reduce it further to avoid the bleeding.
How often are you using Manta? Is that your standard closure device, or is it only on certain patients?
Yeah. Yeah, it's our standard closure device, I must say. To all closure devices, it is a learning curve. So we decided not to sort of make a difference between the patient, for instance, that has a lot of calcifications to use other devices for closure. What we do is, of course, in certain patients, Manta has certain failure rates, so if they're obese or if there's a lot of calcifications, and then we simply put a covered stent in the same procedure.
I mean, that's our worry, that failure of Manta will usually lead into a bigger problem than perclose. So that's why, at least in our practice, we're not using Samir Sushil, you're using.
I mean, we haven't been using it, but it's still per close. I think for those in the audience that aren't familiar, Manta is similar to angiocylinder in concept. There's a foot plate and then a plug that's delivered on top. And so
Okay, Manta was 6.5.
it's done all post, so there's nothing pre. You do some sizing pre with depth, but there's not. It's all done post procedure. But I think Joanna's point is important. There is a learning curve to it, and and it was seen in clinical use of complications. And I think it's because you have to be careful. And I think depending on where you deploy the foot, where the plug goes into, you can embolize stuff down the leg, or if you deploy it above, you can get a retro bleed because it doesn't bleed out, but it bleeds backwards. So I think, as with any device, there's a learning curve, and I think if you're going to do it, you need to do a lot of it, and I think that's an important component.
We have also not
So
been
at
using
least-
it also for the cost perspective also, that it is fairly costly
Yeah, it is.
compared to the...
Yeah. So as you can see, at least from the outside, we don't have any bleeding. We're going to take a picture and see if angiographically, if we have also a good result. It was a bit of a high stick, just at the or just under the circumflex.
So Joanna, what is the minimum size that you have used this Python sheet, the access vessel? What is the size minimum that you have taken or used for your patients?
14 French.
14 French. So
14 French. So it's 14 French for all the MyVal sizes. And the only difference is, of course, you split the sheath with the device itself, which is bigger than 14 French, but it collapses back to 14 French.
you need
And
at
for
least
the valve,
you need at least a 6.5 millimeter vessel minimum.
yeah.
Because if it is
Yeah.
less than that, then sometimes it becomes a little danger to the access vessel.
Yeah, no, it's true. I mean, you obviously need good vessels. She had a blood vessel of
and always 18
9.7.
French dilatation has to be done before you take the valve.
Yeah, exactly. So 18 French dilator I use for MyVal 24.5 and above, and the small sizes go through simply 14 French. So as you can see, perhaps my colleague has already taken the last shot. I don't see any extravasation or any leakage, and he's also actually closing the right groin as well with the angioseal. So I think we are fairly satisfied here with the result, and I think it illustrates how easy this device is to use. I mean, if you have a high volume center, you can do multiple procedures because it goes quickly. I mean, I think, you know, with the presentation and everything, we had skin to skin time less than 30 minutes. So it goes to show that this is very efficient as well.
Amazingly well done. You know, it is looks so simple and well done, so very impressive and very fast.
Dr. Samir, another good part of the MyValve is that it is retrievable. If you face a challenging anatomy or something
True.
happens, then you can.
Same thing with the
Yeah.
come out of the sheath. So the one question,
Yeah. Yeah.
so it
Yeah,
is.
so what I wanted to say, actually, you asked me earlier, will I predilate? And so, you know, with Edwards 29, I tended to do that always, because if I couldn't get it through the valve, I also couldn't get it back. I would have to upsize the sheath on the other groin and do the balloon dilation from the other side first, and then do the valve again. But here, indeed, it's completely retrievable. I can take it out, I can put the balloon in, predilate, and then put the valve again in. So that's also very pretty.
Right. And very well done. You know, it is amazing that we are able to do this tower 10 years ago. This kind of procedures were still questionable, and now it is so reproducible and so easily done, especially in the small sinuses and calcified valve. And you're not even doing an echocardiogram to check if there is an annular issue. So this just tells that how far we have come along in this this procedure.
Yeah.
And how long are you going to
And the
keep the
pa-
patient
yeah.
in the hospital?
I think she can go home tomorrow, actually, if her echo is fine. I mean, some people send them even the same day home, but I mean, she's 88. I think it would be nice of us to give her a meal and keep her here overnight. No, but indeed, you know, we have, she feels well. She has a perfect blood pressure. She has no new conduction system abnormalities. She has no growing complication right now. Yeah, I think tomorrow morning.
Wonderful. Thank you very much again for the great case. Any comments, Pradeep?
No, that was extraordinarily demonstrated. Nice valve selection, procedural steps, and thank you for all the teaching along the way. Any questions from the audience, real quick? No, I think everybody's happy with your performance. Great.
Thank you.
Fantastic
Thank you
result.
again for the
Yeah.
great case. Thank you.
Thank you so much, and we hope to welcome you more often in Groningen.
Thank you.
Have a good afternoon and rest of the Congress.
Take care. Bye. Okay. We have a